Namaskaram. At the outset, I would like to thank Dr. Manikandan and Dr. Kiran for inviting me for this meeting. This is the first time I am actually attending this elite meeting. Somehow in the previous years I could not attend because of personal issues. And this is a very fantastic meeting which is happening every year. And we have with us today Dr. Deepak Nandan, Dr. Thrudeep Sagar, Dr. Antony, and Dr. Krishnakumar to have a discussion on pulmonary embolism, the diagnostic challenges as well as the treatment. So, obviously, we'll start with a case presentation or a 30-year-old male smoker with no comorbidities, presented with sudden onset of chest discomfort, breathlessness, and patient was having hypertension and troponin is elevated. And as most commonly diagnosed, we'll consider probably a myocardial infarction. But then the ECG did not show any evidence of myocardial infarction. And obviously, we are considering a case of a pulmonary embolism here because this is a discussion on pulmonary embolism. So, but the clinical presentation of pulmonary embolism can be so much varied. But it is very important because it is one of the the third commonest cardiovascular disease other than stroke and myocardial infarction, which produces morbidity and mortality. Because the presentation can be so varied, we may miss the diagnosis, and the investigative modalities are also so varied, so that we have to have an idea how to utilize these investigations. So in a severe obstruction to the pulmonary circulation, there can be hemodynamic disturbance, but most of the cases it may not be. So we will start our discussion in the diagnostic challenges. So what are the common symptoms and as well as the clinical findings a patient may present if the patient is having pulmonary embolism? Dr. Deepak, can you discuss on that?
Thank you, Cibu sir. Good morning to all. As sir suggested, problem with the pulmonary embolism is that it can misguide you. Basically, because symptoms can be very non-specific. Secondly, it can mimic all lot of other diseases. So when you are dealing with a patient of pulmonary embolism, suspected pulmonary embolism, you should always keep in mind that symptoms can be very non-specific, starting from an asymptomatic patient in almost 5 to 15% of the cases, to a rapidly progressing shock, collapse, syncope, and death. So the wide range of symptomatic presentation should be kept in mind. And if you take percentage-wise, dyspnea is the common acute onset, gradually worsening dyspnea is the most commonest presentation, followed by chest pain, hemoptysis, and in 5 to 10% of the patient, syncope. So always keep in mind that these symptoms, whenever you find a patient with dyspnea or chest pain with no other obvious cause, always think about pulmonary embolism in the back of the mind. When you take the same signs of pulmonary embolism, usually feeling of anxiety or tachypnea is the most common symptoms that you can see, followed by tachycardia, hypotension, hypoxia. If there is a massive embolus and the patient is having a right heart failure, you will find features of right heart failure also, like a RVS3 or elevated JVP or repeated edema. And in certain patients, the patient comes in shock, you will have features of altered mental status and even seizures. So there are a wide variety of symptoms and signs that you may see a person with pulmonary embolism.
Thank you, Deepak. So the common symptoms are acute dyspnea, which can be sometimes very acute or it can be gradually progressing. And many patients can have tachycardia and tachypnea. And so we have to have a high index of suspicion because these symptoms are actually very common symptoms in other diseases also can have these symptoms. So there may be certain situations where there may be certain predisposing factors. So when a patient is having predisposing factors for pulmonary embolism, you have to be more considering this possibility of pulmonary embolism. Dr. Thrudeep, can you discuss on the predisposing factors?
There are various predisposing factors for pulmonary embolism actually. So that includes basically those patients who are bedridden, so major trauma, surgery, lower limb fractures, spinal cord injuries, etc. Other than that, estrogen containing oral contraceptive agents, and definitely you should always remember about malignancies, because those are the ones that are having a long-term effects on chances of pulmonary embolism. So pancreatic cancers, hematological malignancies, etc. Carrying highest risk for pulmonary embolism. Definitely blood transfusion is one of them, and erythropoiesis stimulating agents are also major factors that are risk factors for pulmonary embolism. Thank you.
So we all know Virchow's triad, that is stasis, injury and hypercoagulability, endothelial injury. All these can produce a risk of thrombosis, but the risk of venous thromboembolism is, the risk factors are almost the same as risk factors for atherosclerosis also. There can be lifestyle, inherited or acquired inflammatory conditions which may predispose a person to DVT formation as well as pulmonary embolism. So we have to have an idea whether the patient is having risk factors and then evaluate. But then, before going to the investigations, when you are suspecting a case of pulmonary embolism, you have to look at the likelihood whether a patient is having a pulmonary embolism. Is it a low likelihood and is it a high likelihood? And then evaluate accordingly. So, Dr. Antony, can you discuss on the assessment, pretest likelihood of pulmonary embolism?
So once you have a suspicion of pulmonary embolism, it's an extension of the risk factor. So it's a history and you're extending the history. So it has a validated score. How much your suspicion is having a clinical probability of high. So there is a validated score, so Wells score as well as modified Geneva score. So here it is mainly the clinical, that is the previous, you can ask the history of previous pulmonary embolism or DVT. You can ask surgery or immobilization. This immobilization starts from the obvious surgery or a fracture, or it's a long journey over the air. So, and then whether the patient is having hemoptysis, had or active cancer, and clinical signs of DVT, an alternative diagnosis less likely. So in the original version, it is 1.5, it might be a little difficult. So you can go for the simplified versions where you have only 1 score. And in the modified Geneva score, along with it, it's an addition of age more than 65. So you can add on, and if there is a 3-level score, low, intermediate, and high. If the value is more than 7, it is high likelihood. And in the Geneva, if the value is more than 11, and in the next slide, value is more than 11, and in the simplified version, if it is more than 5, then you have a more high clinical susceptibility of pulmonary embolism, and they can go ahead with the investigations.
Thank you.
So this is the average confirmation on the different scores. When you take the 2-level classification, you can see that the P likely category, it's only 30%. So it is better to go for the 3-level scores where the high probability, there is 65% of sensitivity is there. Comparing both, taking into both.
So we have to know that there are certain scoring systems which will help you in assessing a patient and categorizing them to a high likelihood or low likelihood, and then manage accordingly and investigate accordingly. And as Dr. Antony said, some of these things in the criteria are the clinical features, some are the risk factors, and whether there is an alternate diagnosis possible. You take into these things together and come to a scoring system. And it is difficult to by heart it, but then with the use of mobile apps, you can always use this. So based on this pretest probability, we are going to investigate a patient. But then what are the common investigations which we are going to use, which are available? Dr. Krishnakumar, can you discuss on that?
There are a lot of investigations in pulmonary embolism, but we have to choose the right investigations according to the pretest probability, because it can increase the cost as well as it can result in certain complications because of this investigation. So there are a lot of investigations in the form of electrocardiogram, chest X-ray, D-dimer, compression ultrasound, echocardiogram, imaging in the form of CT pulmonary angiogram, and ventilation perfusion scan.
So there are lots of investigations, and also ABG also will help. But these investigations are there. We will be discussing each one by one, but can you discuss more about ECG and X-ray? Because
Yes,
these are the commonly available ones.
ECG is a basic investigation that you will do in a patient presenting to the casualty with sudden onset of breathlessness or chest pain. It definitely helps to exclude acute coronary syndrome in the form of ST elevation MI. A 12-lead ECG definitely helps to rule out an ST elevation MI. And the most common abnormality that you will see in a pulmonary embolism is sinus tachycardia. Approximately 40% of the pulmonary embolism cases will have sinus tachycardia. And a huge thrombus occluding the pulmonary artery can result in RV pressure overload, and it can result in certain specific features in the ECG like S1, Q3, T3, RV strain pattern, that is T inversion in the precordial leads like V1, V2, V3, incomplete or complete right bundle branch block, or atrial arrhythmias in the form of atrial fibrillation. This is a patient with pulmonary embolism having S1, Q3, T3 in the ECG.
Okay.
Then coming to X-ray.
So that is one important thing, as Krishnakumar said, is that it excludes other diagnoses also, because acute myocardial infarction you can exclude, may not exclude, but you will get a clue from that.
And coming to X-ray also, it helps to rule out other causes of dyspnea like pneumothorax or pneumonia. And a normal chest X-ray with severe dyspnea, again, it is a clue to suspect pulmonary embolism. There are some named signs like Fleischner sign, that is enlarged pulmonary artery, Hampton's hum, that is peripheral wedge-shaped opacity due to lung infarction, Westermarck sign, that is focal oligemia due to a massive central embolic occlusion. 35% of the patients can have pleural effusion, and also you can see an elevated hemidiaphragm in patients with pulmonary embolism.
So you have put some slides also.
This is a patient with a huge pulmonary embolism. You can see that there is a increased radiolucency in the left upper and mid zone. This can easily be missed in our routine clinical practice, but if the history and other features are, if there is a suspicion, definitely you have to look into it. And this is another X-ray showing a dilated pulmonary artery, that is called as Fleischner sign. And another is Hampton's hum, that I already mentioned. That's a peripheral wedge-shaped opacity due to a pulmonary infarction.
So again, the X-ray is very useful to exclude other other etiologies of acute dyspnea, and you will get a clue regarding the acute pulmonary embolism from the X-ray. So these two investigations are very commonly used and very useful. But then there are other investigations also, and one among them is the D-dimer test. As you all know, D-dimer test is probably one of the overused tests. A lot of people, even the lab people also do a D-dimer test, especially in the COVID era, they do a D-dimer. So what do you think about D-dimer? Should we use it all for all patients? What is your take on the Deepak?
Sir, as we all know, D-dimer is a result of the endogenous fibrinolysis that happens in our body as a result of the thrombus that is being formed. So it actually in a normal individual also it can be there, 3 to 4% of the patients. And this amount of D-dimer gradually increases as we age. So what we do is that because there is endogenous fibrinolysis and the D-dimer, this can be used to detect the presence of thrombus. So there are various assays like ELISA or immunofluorescent assays where we use monoclonal antibody to detect D-dimer. This can be very helpful in a setting to rule out a pulmonary embolism rather than rule it. So when you use a cutoff of 500 nanogram per ml or 0.5 microgram per deciliter, you can almost 99 to 100% you can rule out a pulmonary embolism in a patient with low to moderate risk pretest probability for pulmonary embolism. You need not do a D-dimer in a patient with a high probability of pulmonary embolism. You are wasting your resources, and many times it may come as negative also if you are doing it very late, or if the thrombus load is low, and if it's an upper extremity thrombus and all, it may come negative also. So it's actually a rule out test rather than a rule in test. And after COVID and the critical care culture, all the patients we see, they tend to do a D-dimer, and it seems to be elevated. Particularly in pregnant patients, there is a lot of confusion. It's normally elevated in pregnancy patient and gradually goes elevated in the second and third trimester. So there you have to keep a higher cutoff. And when you're doing a D-dimer for an aged patient above 50 years, there also you have to keep a higher age-adjusted cutoff for interpreting it. D-dimer is not a standalone test to diagnose. It's just to rule out pulmonary embolism.
Thanks, Deepak. So D-dimer is basically to rule out pulmonary embolism, helps to rule out in low probability situations. And when the probability is very high, it is not useful because it can be normal, even normal. And second, many hospitalized patients will have elevated D-dimer, so it is also not useful. And age, as you said, age into 50, 10, above 50 years of age, it may be useful. So we have to selectively use D-dimer test. So, but then what are the definitive diagnostic tests? Definitive diagnostic tests may be an imaging test in higher situations. So can you discuss on imaging specific for the diagnosis of pulmonary embolism, Dr. Thrudeep?
So basically, those patients who are having high risk probability of pulmonary embolism, you need not go for a D-dimer test. So the imaging is the gold standard. So out of the gold standard imaging, CTP-A is the one that will be definite diagnosis for pulmonary embolism. Why? Because of this low or intermediate clinical probability of pulmonary embolism, there is a negative CTP-A had a high negative predictive value for pulmonary embolism, and a positive predictive value of a positive CTP-A was high in 90 to 96% patients with an intermediate or high clinical probability, but much lower in patients with a low test likelihood. So this is one of the cases that I had attempted to do a catheter-based thrombolysis, in which you can see that there is an enlarged MPA and RPA, that is a main pulmonary artery, right pulmonary and left pulmonary artery, and T that appears as thrombus on the left side with poor there is a filling defect on the left side. So the advantages of CTP-A is readily available, excellent accuracy, and a strong validation in prospective management outcome studies, and a low rate of inconclusive results. While disadvantages are definitely radiation and exposure to iodine contrast. So in pregnant patients and all, you cannot use the CTP-A, and tendency to overuse because of the easy accessibility. And radiation dose is about 3 to 10 millisieverts. So next investigation is the length scintigraphy. There are two methods, that is planar and SPECT. Now, why it is being utilized? Because it's low radiation, outpatient level with a low clinical probability, young patients it can be used, pregnant, and history of those patients who are having anaphylaxis with contrast, and those patients who are having CKD. Because of the contrast injury, it can produce renal failure. So overall, the symptomatic patients with a mismatched perfusion defect on V/Q scan for more than 3 months after an acute pulmonary embolism are referred to a pulmonary hypertension clinic, and taking into account the results to echocardiogram. That is, we compare with these results of echocardiogram and natriuretic peptide as well as cardiopulmonary exercise testing. So the pulmonary angiogram is also available. It's also a gold standard, but it is less invasive. It is more invasive as compared to CTP-A. So it is, although it is gold standard, it is not utilized in that manner. So the diagnosis of pulmonary embolism is a direct evidence of the thrombus in two major projections, and thrombi as small as 12 millimeter within the subsegmental arteries can be visualized, which cannot be done in a CTP-A. Thank you. So this is one of the cases that I've already told, that you can see that there is a significant filling defect and there is a huge thrombus in the left pulmonary artery. And this was given a local thrombolysis, and perfusion was done.
So for diagnosis, the imaging, the modalities which we depend upon is basically CT pulmonary angiogram, and there are certain disadvantages also, and certain situations we may use ventilation perfusion scan, but it is not freely available. And the long-term follow-up also, CT pulmonary angiogram is very useful. But then we get, there are other investigations, imaging also, like ultrasound, like echocardiography, for ultrasound of the lower limb veins for DVT. So these are easily available, and bedside investigation which is available. And sometimes we depend on these investigations for an early diagnosis when CTP is not possible. So Dr. Antony, can you discuss on the utility of echocardiogram in the management as well as the diagnosis and management of pulmonary embolism?
So you can see, once we suspect, the readily available tool and the powerful tool, not only for the cardiologists, I think the emergency medicine or the physicians is the echocardiography. So what we see in the echocardiography is simplified in this. In the plaques view or the 4-chamber view, you see an enlarged RV. Normally what we see is the LV side is the enlarged, or the normally it is larger than the RV. So here the plaques view, you get an enlarged RV. In the 4-chamber view, you get an enlarged RV with free wall hypokinesia, that is on the arrow. And in the short axis view, you get a flattening of the interventricular septum, or you say a D-shaped septum. And then when it goes in the subcostal view, you see the IVC, you get a congested IVC with a reduced inspiratory collapsibility. So little more going into the detail, you can see when the pulmonary acceleration ejection time, usually it is 110 milliseconds. That is when the PA pressure increases due to the embolism or the thrombus, the PA pressure increases. So the time decreases and it reduces to less than 60 milliseconds with the mid-systolic noise. And along with it, there is a tricuspid insufficiency which results in the tricuspid gradient of less than 60 millimeter. And less chance of seeing a thrombus actually in the right heart cavities, but it is there. Definitely you can suspect, you can diagnose that. And then these are the features, and then comes to the RV function. So when you check for the TAPC, in the M mode, you can see less than 16 mm, it shows an RV dysfunction. Similarly, the tissue Doppler, if you get a velocity of less than 9.5, you get a dysfunction RV. So these are the normal or the not only the broad spectrum of echo findings that you can see in the pulmonary embolism. And so not only for the diagnosis, actually also for the prognosticating. So when your patient comes in the emergency with a shock, you can see that you do an emergency echo. So you are not seeing any of these features. So absence of signs of RV overload or dysfunction, you can practically exclude a massive pulmonary embolism. And it also helps in the other diagnosis. When sometimes you may see a pericardial effusion, a tamponade or a valvular dysfunction, or a regional valve motion or an LV dysfunction or an aortic dissection if you carefully look, or hypovolemia. So here the importance of echo is an unstable patient with the positive findings of RV dysfunction or RV overload. And if CTPA is not feasible in the center, that in itself is enough to justify our primary reperfusion therapy to salvage the life of the patient.
So, I continue?
Yeah, so that is for the diagnosis. So not only for the diagnosis, for the risk stratification, you can see that it is classified when the severity of the pulmonary embolism is classified into high, intermediate and low risk. So in the high, if hemodynamic instability is there or hemodynamic instability is definitely going for high, we don't go for we do the echo, we don't go for the PSC scoring and troponin. But when you go to the hemodynamically stable patients, intermediate, it is differentiated into high and low based on the pulmonary embolism severity index score as well as the RV dysfunction. So that is given an important role because it helps or it prognosticates for the 30-day mortality risk. So that is the importance of echocardiography in the diagnosis as well as for prognostication.
It is useful in diagnosis, but it is more useful in that management decision to stratify a patient to a high risk or intermediate high risk situation where there is a significant RV dysfunction or such situation patients you have to be very careful and you may have to monitor more aggressively. But in many of the patients, large majority of the patients are having a small pulmonary embolism, not massive pulmonary embolism. And such situations, the echo may be usually normal. And it does not exclude pulmonary embolism. And such situations, echo may not be useful in diagnosing also. But it will give a clue when the patient is having significant massive pulmonary embolism and patient presents with acute presentation and CTPA is not available. You may take a early diagnostic clue from echo. Thank you so much. So there are other investigations also, but we commonly use so many biomarkers like troponin, BNP. Again, just like D-dimer, we are using troponin for every patient, including fever, UTA. Everybody coming to the hospital sometimes get a troponin. What do you think about troponin, Dr. Krishnakumar?
In fact, troponin is not for diagnosing a case of pulmonary embolism. It is basically for risk stratification. And increased value of troponin has got a poor prognostic marker in acute pulmonary embolism. It stratifies intermediate risk into high and low. And it is not useful as a standalone test for diagnosis. And it has got a high negative predictive value for absence of adverse events. A value less than 14 picogram per ml, the negative predictive value is almost 98% for excluding an adverse in-hospital outcome. And age-adjusted value, that is for age less than 75, 14 and age more than 75, 45, has got a much better negative predictive value. And We have other biomarkers like NT-proBNP and BNP. It is almost similar to cardiac troponins. It has got a low specificity and a positive predictive value if high, and low levels has got high sensitivity and a negative predictive value to exclude early unfavorable outcome. Hard type fatty acid binding protein, in fact, it is an upcoming molecule, not yet coming into the routine clinical practice. We have other biochemical parameters like increased lactate, elevated serum creatinine, hyponatremia, increased vasopressin. All these are markers of poor prognosis in acute pulmonary embolism.
Thank you. So basically, these investigations like troponin and BNP are not useful for diagnosing pulmonary embolism, but to risk stratify into high-risk situations. And routine use of troponin as an initial diagnostic test is not needed, but you can risk stratify. So what we were discussing so far was the diagnosis of pulmonary embolism, because a patient can have varied presentation. So you should have first a high index of suspicion to diagnose pulmonary embolism. That is one. Second, you should know the patient's pretest probability. There are several scoring systems like Geneva score or Wells score, and based on the scoring system, you can classify into a low, intermediate, and high. If it is a low probability, then there is something called as pulmonary embolism rule-out criteria. You look at these things, and if none of these are present, and if it is a low probability, then you just exclude pulmonary embolism and you manage other things. You don't even do a D-dimer test. But at the same time, if the patient is having a low probability with at least one of these criteria present, that is age less than 50, heart rate, no tachycardia, saturation is okay, no hemoptysis, no estrogen use, no histo-VTE, no swelling, leg swelling, no recent surgery, none of these are present. If at least one are present with a low probability or intermediate probability, you go for a D-dimer test. And if it is negative, you rule out. And if it is positive, you go for imaging. At the same time, if the pre-test probability is high, then you go for imaging. There is no role for D-dimer. So this is the basic the step in the diagnostic, that is what we were discussing. So after the diagnosing, we are going to the management strategy. So in the management strategy, so how do you, before managing a patient with pulmonary embolism, you have to again risk stratify. Then the management is basically based on the risk stratification. Dr. Deepak, can you discuss on the risk stratification of a diagnosed pulmonary embolism?
When you consider pulmonary embolism, the diagnosis itself is difficult and treatment is yet more difficult. So we have a lot of this course coming into action when you think of pulmonary embolism. Here we stratify patients to ease our treatment pains. So we classify it into a low risk, high risk, intermediate risk, and a high risk group according to ESC classification. And the most common score that we use is a pulmonary embolism severity index score, or PESI score, which has got 11 variables. Actually, it's very cumbersome, so they've made it simple. It's called, we can use for daily use, you can use a simplified PESI score, which consists of 6 parameters, starting from age, history of cancer and heart failure, heart rate more than 110 and systolic BP less than 100, and oxygen saturation less than 90%. If you have at least one score, the category shifts from low risk category to intermediate and high risk. So this is the basic classification of the stratification depending upon the 30-day mortality rate. For a very high risk patient, the mortality rate at the end of 30 days is 20%, and those patients invariably has usually will have a hemodynamic instability. So whenever their patient is having hemodynamic instability, they goes to the high risk category. When there is no hemodynamic instability or any of the PESI score, the patient will become a low risk category. So the patient that comes in the intermediate group with a PESI score of more than 1, there you should look for other parameters like RV dysfunction and elevated biomarkers, as we have already discussed. And if these both are elevated, both are found to be abnormal, then he becomes an intermediate high risk group, which is having a much more worse prognosis than an intermediate low risk group. So intermediate low risk group will be a hemodynamically stable patient with a PESI score of more than 1 and with either an RV dysfunction or elevated biomarkers. This is how you classify. It's a little bit confusing, but the thing is that when you have a high risk pulmonary embolism, you go in for thrombolysis or a catheter-directed therapies. When you have a low risk patient, you send the patient with anticoagulation. You can either send the patient home and manage his OP. When there is intermediate, you should always consider admitting the patient and anticoagulating the patient and monitoring the patient for worsening of his hemodynamic status. And this is the definition of hemodynamic instability as given by the ESA 2019 guidelines. You have 3 parameters. One is a cardiac arrest which needs cardiopulmonary resuscitation. Second is an obstructive shock component, which is that systolic BP less than 90 millimeter or requiring vasopressors to maintain above 90, and the presence of end-organ hypoperfusion like altered mental status, cold chlamydia, oliguria, etc., or persistent hypotension when the systolic BP is 90 or drop of 40 millimeter systolic pressure lasting more than 50 minutes, which is present, you can classify them to hemodynamically unstable patients.
So, thank you, Deepak. So, a patient who has got hemodynamic instability with a diagnosis of pulmonary embolism, it's a very high risk. So, you have to aggressively manage that patient. Whereas a very low risk patient may be there, where you look at the scoring system, and very low risk patients you can probably even manage outpatient based. Then there is an intermediate risk where the patient is not having hemodynamic instability, but there are other features like RV dysfunction or the BNP or troponin may be elevated. So intermediate high risk or intermediate low risk. Such patients you may have to aggressively follow up these patients. So the next question is to Dr. Antony, Dr. Thrudeep. So based on the risk scoring, how do you manage, what is the management pattern based on the risk scoring? What is the basic management pattern? Like, what is the basis of the management in pulmonary embolism? That is what I'm telling.
So basically, a patient is coming to you with hemodynamic instability or not. The pulmonary embolism patient who is getting admitted to the emergency department with hemodynamic instability, he is high risk. Now, if hemodynamic instability is removed, now you are having other parameters. That is the clinical parameter, RV dysfunction, and elevated troponins. Now, if all these parameters are present, that is an intermediate risk. And low risk, you don't have any of this, that is instability or clinical suspicion or even RV dysfunction. Sometimes there may be elevated cardiac biomarkers. Now, with this, we can have 3 methods by which we can do the management. First of all, we should make sure that the patient is stable, having adequate oxygenation. IV fluid should be started, and then immediately you have to think about the reperfusion strategies. So, out of the reperfusion strategies, you are having anticoagulation, lysis, as well as thrombectomy. So, these all are having, as per guideline-based class 1 indication in hemodynamically unstable patient. Next slide. So with this, a bedside RV patient is coming, you are looking for the ECG, echo, there is RV dysfunction. Yes, you can go around for a CTPA. If CTPA facility is present, then you can go to a CTPA, and if it is not present, you can directly go for immediate treatment for pulmonary embolism. And if the patient is not hemodynamically stable, then you can go ahead for a D-dimer test, and if it is positive, again you can go for a CTPA, and if CTPA is positive, you can do the treatment. Now, if there is a high clinical probability, you can directly go for CTPA, don't do D-dimer, and then confirm it and do for pulmonary embolism treatment. So this was earlier discussed, but so basically in hemodynamically unstable patient, you can go directly for the reperfusion therapy. If it is a stable patient, you can select that is RV dysfunction as well as the clinical probability. And then if the treatment is started, you can look for the treatment success by doing an echocardiogram. And if it is treatment failure, that is patient's clinical as well as RV dysfunction is not improving, we think that the patient is in treatment failure and you have to improve the reperfusion strategies.
Thank you, Dr. Thrudeep. So I will summarize like this. The mainstay, backbone of the treatment of pulmonary embolism is anticoagulation. So all patients here to anticoagulate, intermediate risk, low risk or high risk patients. High risk patient who has got pulmonary embolism which obstructs and produce hemodynamic instability, you have to remove that obstruction by thrombolytic therapy or by mechanical measures. Intermediate risk and low risk, only anticoagulation is required. But in intermediate high risk patients, thrombolytic therapy is not recommended, but you have to watch the patient. That patient can deteriorate, and if the patient deteriorates, then you have to give thrombolytic therapy. And we have already discussed what is the hemodynamic instability, what do you mean by hemodynamic instability. So thrombolysis is only for hemodynamic instability. But what about the anticoagulation? I said that anticoagulation is the basic backbone. Can you discuss more about anticoagulation, Dr. Antony?
So this plan of anticoagulation starts from the initial history taking itself. So you, from the clinical probability, you suspect a high or intermediate risk, that is clinical probability score, then initiate the parenteral anticoagulation then and there itself before getting the investigation. So parenteral anticoagulation, three things: intravenous unfractionated heparin, subcutaneous low molecular weight heparin, and subcutaneous fondaparinux, which is readily available. Our setting would be giving a bolus dose of unfractionated heparin followed by a continuous infusion. But what preferred is actually low molecular weight heparin or fondaparinux. And unfractionated heparin, actually we start in the setting if a patient is going for a hemodialysis. Basically in the intermediate, high risk and low risk, you have to hospitalize the patient. Only in a category where there is a very low risk, you can keep it in outpatient or you can discharge the patient. So once hospitalized, it is always better to go initially with the unfractionated heparin bolus dose of 80 units per kilogram followed by continuous infusion and keep an APTT of 1.5 to 2.5 and then closely monitor. The issue comes when there is a intermediate high risk group or a low risk group where you have an RB dysfunction plus or minus troponin, and sometimes they may deteriorate. So if it is unfractionated, you can stop and you can do the thrombolysis bar the catheter mediated therapy, it's okay. But when it is a low molecular weight, the duration of action is little low and so it's not advisable. So the basic will be the parenteral anticoagulation. Initially before NOACs, it was just vitamin K antagonist and followed by up to 3 months. So here coming to the last one where you have a low risk category where you can discharge the patient or discharge the patient not like based on the PESI scoring as well as on the STS scoring system. So in that you can start apixaban according to the Amplify as well as the rivaroxaban according to the Einstein trial. You can start 10 mg BD for the first 7 days for apixaban followed by 5 mg BD for 3 months. And in certain cases, if you have to extend the duration of NOACs, you have to go for a low dose in case of an apixaban, 2.5 mg BD. So this is the hasty exclusion criteria for outpatient management. So if any of the questions answer is yes, there is no outpatient, he has to be admitted and he has to be on parenteral anticoagulation. So that is a questionnaire where the patient is hemodynamically unstable, whether is thrombolysis or embolectomy necessary, active bleeding or high risk bleeding, more than 24 hours of oxygen supply, severe pain needing IV medications, does the renal dysfunction or liver impairment, or is the patient pregnant?
Thank you, Dr. Antony. So anticoagulation is the mainstay. And which anticoagulation do you prefer? Vitamin K antagonist or DOAC?
NOACs are preferred more than vitamin K.
NOACs are preferred. Any situation where vitamin K antagonists are preferred?
There are situations where you have an APLA syndrome or you have a severe renal failure where the creatinine clearance is less than 15. Because apixaban you can use up to less than 15 and more than 15 less than 30.
In APLA, it is vitamin K antagonist.
Vitamin K antagonist. And similarly in the severe liver dysfunction also, you have to go with the PK.
So next we'll go to the lytic therapy. We have already touched upon lytic therapy, so you can quickly go. What is the?
There are already discussed the lytic therapy. Only indication is pulmonary embolism patient with hemodynamic instability. So the indication is systemic thrombolytic therapy is recommended for high risk pulmonary embolism, and for intermediate and low risk we have to keep a watch on the hemodynamics. If it deteriorates, definitely you have to go for lytic therapy. And thrombolytic therapy is a preferred reperfusion strategy. It decreases pulmonary artery pressure, decreases pulmonary vascular resistance, RV dilatation and dysfunction. And the greatest benefit is obtained when the treatment is initiated within 48 hours of symptom onset. But still we can give the medication for 6 to 14 days. And failure of lysis is assessed at 36 hours. And 92% of the patients will have clinical and echo improvement. And is there a role for lytic therapy in intermediate risk is assessed in the PITO trial. Found that there is hemodynamic improvement at the cost of fatal bleeding. So it is not recommended at all. And we have 3 agents approved for thrombolytic therapy: streptokinase, urokinase, and recombinant tissue plasminogen activator. The preferred one is recombinant tissue plasminogen activator. Streptokinase, the regimen is 2.5 lakh international units as loading over 30 minutes, followed by 1 lakh units per hour over 12 to 24 hours. And recombinant tissue plasminogen activator is 100 milligram over 2 hours. We have certain contraindications that is almost same as that of lytic therapy in acute myocardial infarction. And the only indication for percutaneous catheter-directed treatment is when the thrombolysis is contraindicated or has failed. That is given class 2A recommendation in ESC 2019.
So, thrombolytic therapy, here you can have a wide window. That is the one thing which I want to stress. In acute myocardial infarction, you take the window period as 12 hours or even 24 hours. But in pulmonary embolism, you can lyse even after 1 week, 2 weeks, and we have found significant improvement even after that. So, there is a wide window. And the thrombolytic therapy is given at a low persistent infusion for 24 to 48 hours, 1 lakh units per hour infusion. Especially streptokinase. So, coming to the catheter-based intervention, what about catheter-based intervention? Is it the new thing? What about that, Deepak?
Sir, if you consider the non-pharmacological interventions for pulmonary embolism, it broadly comes under percutaneous interventions, surgical embolectomy.
Okay, surgical.
Then you have a pulmonary endarterectomy for CTPH and IVC filters. But you take percutaneous interventions, the most common that we see here is aspiration thrombectomy or your pigtail, the mechanical thrombectomy that you and the catheter-directed thrombolysis you do with your pigtail or specific catheters that we use. That comes under the thrombus fragmentation and certain specific things like angiojet, which use saline flush to do rheolytic thrombectomy. So the basic idea is to rapidly reduce the pulmonary artery pressure and RV strain and increase the systemic perfusion and facilitate RV recovery. That is the most important aspect of this percutaneous catheter intervention. So the indications, as we have discussed, it's basically in a high-risk pulmonary embolism when there is contraindication for systemic thrombolysis or there is a failure of systemic thrombolysis is a class 1 indication, especially the surgical embolectomy. So percutaneous is a class 2A indication as per ESC guidelines. In an intermediate high-risk pulmonary embolism also, when you give anticoagulation, the patient is going for instability and there is contraindication for anticoagulation, you can consider percutaneous therapies. Next slide.
The guidelines do not recommend this as the first-line therapy, basically because there are not much trials, that's all. But in massive pulmonary embolism, definitely this is going to be much more effective than thrombolytic therapy in removing the clot. And in the future, in coming years, probably such situations with the availability of these instruments, I think probably that will be the treatment of choice. So these are some of the pictures here put regarding the different systems available. And what about inferior vena cava filter?
Filters should be considered in patients who have contraindications for anticoagulation to prevent a pulmonary embolism in a case of DVT. Or a case of recurrent pulmonary embolism in patients with failure of anticoagulation.
IVC filter can be used. So again, there are certain patients who can have recurrence because the time is running short. Can you just give an idea who can have recurrence, more recurrence?
So there is an 8% chance every year for high-risk group because of those patients who are having an active cancer, one or more previous episodes of venous thromboembolism, definitely antiphospholipid antibody syndrome, protein C, protein S deficiency, factor V Leiden, etc. But coming to the low risk, that is less than 3% surgical patients who had undergone general anesthesia for not more than 30 minutes, confined to bed in the hospital for more than 3 days, trauma with fractures. While intermediate to high risk like group, minor surgeries, admission to the hospital less than 3 days, estrogen oral contraceptives, then pregnancy, peripartum, leg injuries, long haul flights, etc. So basically, there is no term like unprovoked or idiopathic venous thromboembolism. Patient in whom index episode occurred in the absence of an identifiable risk factor. That is the only criteria.
So you have to, there are certain patients who are at high risk. Definitely you have to probably continue anticoagulation for a longer period in such situations. So what is the duration of the anticoagulation? We have already discussed in very short.
So according to both ESC as well as AHA guidelines, more than or equal to 3 months of anticoagulation is recommended for all patients with diagnosed as pulmonary embolism. So with first episode of pulmonary embolism, which is secondary to a major transient or a reversible factor, then there is a discontinuation of therapeutic anticoagulation is recommended after 3 months. But you have a recurrent pulmonary artery embolism, oral anticoagulation of indefinite duration. Similarly, first episode with no identifiable risk factors, it is indefinite anticoagulation, which is class 2A. Similarly, for APLS syndrome with pulmonary embolism, it is anticoagulation with indefinite period. Also, along a cancer patient, it is class 1 to continue anticoagulation for 6 months, and cancer patient, it's a low molecular weight heparin which is advised for 6 months, followed by it can extend which is class 2A. Thank you.
So you want to,
Okay, so as we all discussed, NOACs are the preferred one, and weaken certain conditions like cancer patients as well as APL.
in the previous discussion, I already discussed the dose also. It is a lower dose for a continuation. So standard treatment is anticoagulation is given for 3 months. And subsequently, if the patient is having, you think that the patient is having high risk of recurrence, which Thrudeep has already said, will continue anticoagulation, others. But then previously there was a practice of looking at thrombophilia. Do you look at these tests like factor 5, these tests routinely, or do you have to do that?
It's not routinely performed because the test cost is pretty high, especially done in certain situations. If the venous thromboembolism occurs at a younger age, if there is no otherwise identifiable risk factor, strong family history of venous thromboembolism, or the patient has got recurrent episodes, you can go for thrombophilia workup.
So it is not routinely done. One problem is that when you have already started anticoagulation, your test is not going to be good. Second, routine use of this test has not been found to be useful in further recurrence. So it is generally not routinely done, and none of the guidelines recommend routine tests. But then when there is a recurrence, they can do that. And what about the long term, like chronic one word about chronic thromboembolic pulmonary hypertension. When do you suspect that?
If the patient is at the follow-up, actually all pulmonary embolism patient you have to follow up at 3 months. And if the patient is having persistent dyspnea, definitely you have to evaluate for chronic thromboembolic hypertension. The patient should be sent for a transthoracic echocardiogram. If there is pulmonary hypertension in transthoracic echocardiogram, the patient should be sent for ventilation perfusion study. And if there is a mismatch in ventilation perfusion, the diagnosis of chronic thromboembolic hypertension is confirmed, and such patient should be referred to an expert center where that is treated. And the only treatment, the main treatment option for chronic thromboembolic hypertension is surgical endarterectomy, and it has got a very good result in experienced centers, and the mortality is also pretty low.
So the thing is that following pulmonary embolism, you have to follow up the patient, and if the patient is significantly symptomatic, so it is pulmonary embolism, the patient is dyspneic, you have to evaluate for any pulmonary hypertension. There is pulmonary hypertension, then you have to go for CT or ventilation perfusion studies. So the case which we had discussed initially, this is a 30-year-old person who presented with acute dyspnea, and the BP was 80/50. Troponin was elevated. The question is there a role for D-dimer? As we have discussed, there is no role for D-dimer. Is it a high-risk patient? Okay, so this patient has got S1Q3T3, and in the echo, the RV is dilated, and we have done a CT, and CT shows a large thrombus. So here there is no role for D-dimer. This is a high-risk situation, and patient should be managed with thrombolytic therapy or removal of the thrombus, and followed by anticoagulation, and anticoagulation should be continued for 3 months, and then subsequently whether to continue anticoagulation will depend upon whether the patient is having any continuing risk for recurrence of thromboembolism. And this is probably another patient, a patient who was a recent surgery, who was on a plaster cast for some time, and patient developed a pulmonary embolism. So there is a reversible risk factor. And this patient presented with chest pain. So do you want to do a D-dimer? So again, here you can look at the well score, and you can look at the well score, and the patient is having tachycardia, pulse is high, and the patient had a reason for developing pulmonary embolism. So when you do the score is high. When the score is high, actually there is no role for D-dimer. You can go for imaging. And imaging showed a pulmonary embolism, but here the patient is hemodynamically stable, so did not thrombolize the patient. Anticoagulation was done, but subsequently when the patient deteriorated, actually a thrombolytic therapy was done, and that is the way to go. So I think for lack of time, we'll stop here because we cannot go for further case discussions because we have exceeded slightly by around 5 minutes. Please excuse Manikandan and Kiran. I think the panelists, Dr. Deepak, Thrudeep, Antony, and Krishnakumar has discussed the various aspects of pulmonary embolism very elegantly. And thank you so much. And